Good morning, everybody, and welcome to this webinar on the central disorders of hypersomnolence. I'm Lynn Marie Trotti. I'm an associate professor of neurology at Emory University in Atlanta. I'm the associate fellowship director of our sleep medicine fellowship there as well. And I am excited to talk with you all about this group of sometimes perplexing disorders. Before we get started, it's important to note that my institution has been a site for clinical trials and expanded access programs for some medications that are used to treat some of the central disorders of hypersomnolence. I don't personally have any conflicts of interest there. I don't get any money from that, but know that my institution has been involved in some of that work. As well, I will be talking about off-label use of approved medications because unfortunately there are no approved medications for some of our central disorders of hypersomnolence. And just as a last housekeeping note, you are welcome to ask questions. You can ask them at any point during the presentation by clicking on the little Q&A button. There will also be time at the end if you want to wait and type your questions in at the end. This webinar is also being recorded in case you want to listen to it that way. It'll be available on the AASM website a week or two after we are done with this webinar. So, the central disorders of hypersomnolence, they are a group of disorders that are marked by excessive daytime sleepiness. That's how those disorders get into this bucket. The International Classification of Sleep Disorders, 3rd edition, the ICSD-3, lists 8 different central disorders of hypersomnolence. The order that you see them on the screen is not the order in which they appear in the ICSD-3, but I've lumped this way for the purpose of today's conversation to sort of say there's a group where the sleepiness is either due to or closely related to another condition. And so those are things that you may need to treat the sleepiness in addition to the primary condition, but you have to sort of think about ruling out some of those things before you make a diagnosis of a primary disorder of hypersomnolence. And then of the remaining 4 disorders, there is one in which sleepiness is episodic and there is no sleepiness in between, and that's Klein-Levin. And then there are 3 where the sleepiness is persistent and pervasive. It's always there and chronic. Note that this lumping into 3 different classifications is not in the ICSD-3. I just find it a helpful way to organize these disorders in my thinking about them. So first, we're going to walk through some of these that are associated with or due to another problem as we talk about some of the diagnostic criteria and clinical features of these 8 disorders. So insufficient sleep syndrome is the one central disorder of hypersomnolence that is arguably not really a central disorder of hypersomnolence, meaning that we think the others are central in the sense that they are probably a central nervous system problem. Insufficient sleep syndrome is behaviorally induced lack of sleep resulting in sleepiness. So it's fundamentally different than the other disorders. In order to diagnose it, there has to be daily sleepiness. And in kids, that actually can manifest as a behavioral problem that's attributable to sleepiness rather than sort of classic sleepiness per se. Sleep duration has to be shorter than whatever is expected for the person's age. The restricted sleep pattern has to be present most of the time for at least 3 months, and it has to be maintained by the person doing something to shorten sleep. So these are not people who have insomnia and can't sleep. These are people who are restricting their time in bed, usually with an alarm or a person waking them up in the morning. But if they're given the opportunity to sleep longer, if they don't use an alarm, they will sleep a sufficient duration. And symptoms will get better with sleep extension, at least if sleep is extended for long enough. So lots of people will have chronic insufficient sleep 8 hours one night and say, but I'm still sleepy, it didn't work. So you have to keep in mind that it takes some time to recover with sleep extension. And like all of these disorders except for one, if you're going to make the diagnosis of insufficient sleep syndrome, it can't be better accounted for by something else, another medical problem, another sleep disorder, and so on. Insufficient sleep syndrome is really a manifestation of, as I said, a sort of a behavioral issue fundamentally. And so it's very different from these other diagnoses. The reason I'm starting with it, rather than some of sort of the neurologically meatier diagnoses, is this is a huge piece of the differential diagnosis of hypersomnia disorders. So it is still amazing to me how often people come into clinic because of sleepiness, but they are routinely not getting enough sleep. And so it's really important to try as best as you can using current tools to figure out how much somebody is routinely sleeping and if sleep extension might be enough to fix their problem. The next central disorder of hypersomnolence we're going to talk about is hypersomnia due to a medical disorder. So here, sleepiness has to have been present every day for at least 3 months. You will hear that for all of the hypersomnia disorders other than Klein-Levin. For the most part, you're looking for sleepiness every day that's lasted at least 3 months. Here, like with the other disorders, it can't be due to something else. It is due particularly to one identified medical disorder. This label implies not just that the person is sleepy and has a medical problem, but that you think with a reasonable degree of certainty that the medical problem is what's causing the sleepiness. Unlike your narcolepsies and to some extent idiopathic hypersomnia, you do not need to do a multiple sleep latency test for the diagnosis of hypersomnia due to a medical disorder. It's not part of the diagnostic criteria that you see any particular multiple sleep latency test results. However, per the ICSD-3, if you are going to do an MSLT in people that you suspect have hypersomnia due to a medical disorder, the mean sleep latency is usually less than 8 minutes. And there should not be multiple sleep onset REM periods because that would imply a diagnosis of narcolepsy, potentially still due to a medical disorder. And so what kind of medical conditions are we talking about here? This list is by no means extensive, comprehensive. It's a long list, but there's lots more. It really tends to be things like neurologic diseases, unsurprisingly, that result in sleepiness, Parkinsonism, and myotonic dystrophy being among the ones where sleepiness has been best demonstrated in carefully controlled studies, but traumatic brain injury is a common cause of sleepiness. Anything that affects hypothalamus, bilateral thalami, or midbrain, from really any kind of pathology, because those areas are so fundamental to the regulation of sleep and wake, can result in hypersomnia. But there's also a slew of medical conditions that can do it. Hepatic encephalopathy, inflammation is very sedating, lots of genetic syndromes carry sleepiness with them, and then probably multiple endocrine diseases, but for the one that is the best characterized is hypothyroidism. And then there is sort of a special case for hypersomnia due to a medical condition within the ICSD-3, and that's people who have sleep apnea. You treat their sleep apnea and they're still sleepy. Those patients are considered to have hypersomnia due to a medical condition. What is important to note about this diagnosis is if you actually look at the criteria within the ICSD-3 for trying to make this case, you really have to be positive that the sleep apnea has been fully treated. So they have to have used their PAP therapy or other therapy for the treatment of sleep apnea for at least 3 months. If they're on PAP, a download should show at least 7 hours of use every night. And ideally, you would do a PSG on CPAP to show that the AHI is controlled at the prescribed settings. We all know that the CPAP download information with the AHI flow is good if the AHI flow is less than about 5, but it is also imperfect. So if somebody is still sleepy, despite good adherence to CPAP, and it looks like the AHI flow is normal, if you can, do a check of that to make sure the machine is accurate and that the sleep apnea is controlled as well as you think it is. Then there's hypersomnia due to a drug or substance. There's actually no duration criteria here, so the 3-month criterion that you heard in the other ones is not present here, but you have to have sleepiness every day, and it has to be caused by a medication. Again, lots of things on this list. There's lots of medications that are sedating, including ones that are prescribed really, really commonly. So of course, sedative hypnotics, but lots of neurologic disease, the anti-epileptic drugs, dopamine agonists are very sedating, especially the doses that they're used in for Parkinson's disease. Psychiatric medications, the antidepressants, the antipsychotics, the benzos, the barbiturates, all can be sedating, but also anticholinergics and antihistamines and muscle relaxants and so on and so on and so on. And it's worth a note that the hypersomnia due to a drug or substance also includes people who are abusing sedating medications and people who are withdrawing from wake-promoting medications. So if you've been on high-dose amphetamines and then you stop them cold turkey, you can actually see sleepiness rebound for as long as 3 weeks. There's also lots of rebound sleepiness that can come from a high-dose caffeine that you start and stop. And so don't just think about what the person is right now taking, but what they have been taking potentially recently and have just stopped. And then there's a special little carve out for hypersomnia comorbid to a psychiatric disorder in the ICSD-3, which is to say that for medications and for insufficient sleep and for medical disorders, the diagnoses imply that the drug or the medical problem or the insufficient sleep is the primary cause of the sleepiness. In hypersomnia comorbid to a psychiatric disorder, the language is different because we don't know what is cause and what is effect. There are probably people who are sleepy because of their mood disorder. There are probably people who develop mood disorders related to their primary sleepiness disorder. There are probably people who have both things that are unrelated. We don't know enough at this point to untangle cause and effect, and so the authors of the ICSD-3 said, we'll just say hypersomnia comorbid to psychiatric disorder and then not make any comment about what is the chicken and what is the egg. So to diagnose this, you need daily sleepiness for at least 3 months. You need a comorbid psychiatric disorder, and you need to not have another explanation for the sleepiness. What kind of psychiatric disorders do this? Well, potentially all of them, but the most common are mood disorders. So atypical depression, regular depression, but particularly atypical depression, bipolar 2, seasonal affective disorders, sometimes anxiety disorders can manifest as sleepiness. And then to some extent, somatoform disorders, less commonly things like thought disorders, schizophrenia, and so on, adjustment disorders, or personality disorders. And this is the one, I think, where the differential diagnosis with our other central disorders of hypersomnolence is definitely the hardest. And frankly, sometimes we don't have enough science to know how to tell them apart. And so if you look at the diagnostic criteria for idiopathic hypersomnia, which we'll get to in a little bit, compared to hypersomnolence associated with a psychiatric disorder, they're hard to tease apart. They both have sleepiness for 3 months. There are some MSLT and objective testing criteria for idiopathic hypersomnia. They don't always work all that well to capture the people who you think have idiopathic hypersomnia. But both diagnosis actually requires that you rule out the other. So idiopathic hypersomnia, you can't think that the sleepiness is better explained by, among other things, a psychiatric disorder. But at the same time, if you're going to diagnose somebody with hypersomnolence associated with a psychiatric disorder, you can't think that's better explained by a sleep disorder, including specifically idiopathic hypersomnia. And this sort of conventional wisdom says that people with psychiatric hypersomnolence spend a lot of time in bed, but have a normal MSLT, while people with idiopathic hypersomnia have a long sleep time and an abnormal MSLT. I think the more these two populations are studied, the more we see that conventional wisdom is not always true. There are some people with hypersomnolence associated with a psychiatric disorder who sleep objectively measured long durations, and about a quarter of them have an abnormal mean sleep latency on their MSLT. So this can be a tough distinction to make, but worth considering in your diagnostic process for things like idiopathic hypersomnia. All right, so those are the 4 sort of sleepiness related to or due to something else. Now we're going to transition to the 4 central disorders of hypersomnolence, where really it is a primary problem of excessive daytime sleepiness that you don't have some other explanation for. So the first one we're going to talk about is Klein-Levin, which is a recurrent hypersomnia. If you look back in the literature or the old ICSD, there used to be multiple different kinds of recurrent hypersomnia. They are now all lumped together under Klein-Levin syndrome. And so the idea with Klein-Levin is you have episodes of sleepiness, and in between sleepiness, people are fine. For the ICSD-3 criteria, you have to have had at least 2 episodes. So a single episode of sleepiness is not enough, but once you've had 2, it's recurrent. The duration in the ICSD-2 is 2 days to 5 weeks. Studies have suggested the median duration of a Klein-Levin episode is 13 days. The recurrences have to happen at least once every 18 months. Usually most patients have at least have more than one in a given year. During these bouts of sleepiness, people will sleep very, very, very long durations. And so it is not uncommon for people to sleep 18, 20, 22 hours a day during one of their Klein-Levin bouts. But as bad as that is not the only part of the recurrent hypersomnia of Klein-Levin. In addition to that sleepiness, patients also have to have at least one other abnormality during their episodes, but not present in between their episodes. And that can be cognitive dysfunction, altered perception, disordered eating, either hyperphagia, which is sort of the textbook, or anorexia, or disinhibited behavior. They don't have to have all of those, they have to have one of those. And data suggests that the median frequency of episodes is between 3 and 6 months. So people will be fine for 4 months at a time and then have 2 weeks of being utterly incapacitated by long sleep times and some of these ancillary symptoms. It is not a disease that is typically lifelong. People do tend to outgrow it, if you will, at some point in their disease course. The median time that people continue to have Klein-Levin spells, though, is 15 years. So people aren't outgrowing it soon after diagnosis necessarily. It is common but not necessary for there to be triggers for each episode or for some of the episodes. The common triggers are infection, alcohol use, sleep deprivation, stress, and head trauma. You don't need to do diagnostic confirmatory testing for Klein-Levin syndrome. There are no MSLT criteria for Klein-Levin syndrome. There is no requirement that you measure sleep duration in any way during a bout. It is hard to evaluate patients with Klein-Levin in the middle of a bout because they're usually asleep, and when you wake them up, they tend to have this altered behavior and altered thoughts. So there's really not a requirement for a mean sleep latency on the MSLT or number of sleep onset REM periods or for monitoring of sleep with PSG or actigraphy. A little more about the symptoms other than sleepiness during the episodes. So, typical sleep in a 24-hour period during an episode is 15 to 22 hours per day. That is a lot of sleep, obviously. The altered cognition often presents with sort of a slowness, a confusion. It is pretty common for people to have amnesia for what happened during their Klein-Levin spells once the spell is finished. Early reports of Klein-Levin really emphasize the hyperphagia and the hypersexuality component of the disorder. Those can be important symptoms, those can be problematic symptoms, but they are far from universal. So hyperphagia or increased food intake during a Klein-Levin spell happens in about 2/3 of people. Hypersexuality is present in about 58% of boys, only about 1/3 of girls. And so those things can happen, but the absence of them should not rule out a diagnosis of Klein-Levin. On the other hand, what we have come to realize is nearly universal, or certainly very, very common, are the symptoms of derealization. So just really a sense that what is happening is not real, like reality is sort of altered in some way. Happens in probably at least 90% of people during a Klein-Levin spell. And apathy is nearly universal as well. And so those things in combination with sleeping 15 to 22 hours a day, again, make people completely non-functional during a typical Klein-Levin spell, even though they are normally functioning in between. If you haven't seen a case of Klein-Levin yet in your fellowship, that's because it's really rare. So it is by far the most uncommon of the central disorders of hypersomnolence. The best estimates about how common it is somewhere between 1 in a million people and 5 in a million people. So this is not a disorder that walks into sleep clinics too terribly commonly. The age of onset is usually between 12 and 20. 2/3 of the patients are boys or young adult men. It is generally not a disease that has a strong familial pattern, but about 5% of people with Klein-Levin have another family member who also has it. So that's the recurrent hypersomnia. And now we're going to dig into sort of the meat of this talk, which is narcolepsy type 1, narcolepsy type 2, and idiopathic hypersomnia, the 3 central disorders of hypersomnolence where sleepiness is present all day, every day, and we sort of don't have another explanation for where it's coming from. So in terms of the ICSD-3 for narcolepsy type 1 and narcolepsy type 2, there are some similarities and then there's some important differences. So these are the criteria for narcolepsy type 1. You have to have excessive daytime sleepiness every day, and that has to have been present for at least 3 months. Then for type 1, you can either have cataplexy and a certain pattern on your multiple sleep latency test, or you can have demonstration of low or absent hypocretin levels, orexin levels, for some parts of the country, 2 names for the same thing, in cerebral spinal fluid. So if you're going sort of the clinical pathway to diagnosis, cataplexy is a clinical diagnosis that you make face-to-face based on their report of episodes of muscle weakness triggered by emotion. And then you do a multiple sleep latency test. You see a mean sleep latency of less than or equal to 8 minutes, and counting both the first REM onset at the start of the night and each opportunity to have REM sleep during the MSLT naps, if there is REM onset within 15 minutes of any of those 6 opportunities, it's considered to be a sleep onset REM period. So 2 or more sleep onset REM periods. There are cases where the MSLT is difficult to interpret or difficult to obtain. There are cases where cataplexy is equivocal. And so it is nice that we have the opportunity to test for hypocretin in spinal fluid as another way to get at this diagnosis. So for people who aren't aware, there is now a clinical test for hypocretin that's a send out to the Mayo Clinic, like many of their other send outs. And so if you have a patient you are thinking about this diagnosis in, you can send spinal fluid and see if they have hypocretin deficiency or not. The cutoff of 110 picograms per milliliter comes from the Stanford reference lab, but other labs will use a different assay, and then the level just has to be has to be less than 1/3 of what control values are, because there are a few assay options. What about narcolepsy type 2? Previously known as narcolepsy without cataplexy. So the same exact language for daytime sleepiness for at least 3 months, the same exact findings on the MSLT, less than or equal to 8 minutes, 2 or more naps, plus the nighttime with sleep onset REM periods. That's why both diseases are both called narcolepsy. They look the same on the MSLT. However, they're very different diseases. And in narcolepsy type 2, there cannot be cataplexy. You don't have to measure hypocretin to make a diagnosis of narcolepsy type 2 or narcolepsy type 1, but if you have measured hypocretin, it has to be above 110 for you to make a diagnosis of narcolepsy type 2. In the diagnosis of narcolepsy type 1, that's the only central disorder of hypersomnia where it doesn't say the symptoms are not better explained by blah, 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 blah. because we think we're pretty good at diagnosing narcolepsy type 1. If you're sleepy and you have cataplexy or hypocretin deficiency, we know that you have it. That is not the case for narcolepsy type 2 because there are reasons to have false positives on the MSLT. And so in narcolepsy type 2, you really have to be very careful to exclude other things that could cause the symptoms and the testing on the MSLT of narcolepsy type 2, like insufficient sleep, untreated sleep apnea, medication use and or withdrawal. So how common are the narcolepsies? Well, there is some regional variability in the prevalence of narcolepsy type 1, but on average, it looks like the prevalence of narcolepsy type 1 is about 1 in 2,000 people. It is not as clear what the prevalence of narcolepsy type 2 is. There are a number of clinic series that sort of say, well, our prevalence, our frequency of patients with type 1 versus patients with type 2 is such and such. Some of those suggest that type 1 is more common. Some of them suggest that type 2 is more common. Our best sort of population data on the question, which is not without its limitations, but it doesn't necessarily have the same referral bias that a clinic might, comes from two sources. One is a medical claims database. So of course that requires people to have accurately coded the kind of narcolepsy that patients had. But this is a medical claims database of 8 million people that found that type 2 narcolepsy was about 4 times more common than type 1 narcolepsy. Similarly, in the Wisconsin sleep cohort, they did testing with PSG and MSLT and found that narcolepsy type 2 is about 3 times more common than narcolepsy type 1. There is some familial risk that goes with both narcolepsy type 1 and narcolepsy type 2. We know that in type 1 patients, there's about a 25 to 31% concordance in monozygotic twins. So there is a heritable component. There is clearly an environmental component on top of that to explain the relatively low concordance rate. This is not a disease where it is only genetically determined by any stretch of the imagination. What is interesting about the inheritance pattern that you'll see in patients with narcolepsy type 1 is that they have an increased risk of having, their family members have an increased risk of having narcolepsy type 1, but actually their family members also have an increased risk of having any hypersomnia disorder. So it's not just the type 1 narcolepsy that is heritable. It looks like there's some sort of tendency towards sleepiness not meeting the full phenotype for narcolepsy type 1 that is also heritable in these patients. So separate from the diagnostic criteria, what does narcolepsy type 1, sort of classic type 1 narcolepsy actually look like? So there is a tetrad of narcolepsy symptoms, and narcolepsy type 1 symptoms is what people mean by that. So sleepiness, you have to have sleepiness to have narcolepsy. According to the diagnostic criteria, it can happen that people manifest cataplexy before the onset of sleepiness, but it is not common. Most people with type 1 narcolepsy do have cataplexy. Now that you can diagnose narcolepsy type 1 by hypocretin deficiency, there are some people who are sleepy and hypocretin deficient who do not have cataplexy, or perhaps do not have cataplexy yet. But most people with type 1 narcolepsy will have cataplexy. And then the other two features of the tetrad are sleep paralysis, waking up from sleep, while the atonia of REM is still maintained, and so people are awake but unable to move. That's about half of people with narcolepsy type 1, maybe a little higher in some other series. These numbers come from a very large genetic study in Europe of narcolepsy patients, and so a good estimate across a fairly large denominator. And then hallucinations at sleep onset, hypnagogic or sleep offset, hypnopompic, in about 2/3 of people with narcolepsy type 1. And so while people talk about the classic narcolepsy type 1 tetrad, not all patients have all 4 things. Two other things that are really common in narcolepsy type 1 are sleep fragmentation and REM behavior disorder. The REM behavior disorder that you see in narcolepsy type 1 is often not what brings people to medical attention. You often have to ask for it to get the history. It does not tend to be quite as florid or dramatic as the REM behavior disorder that you see in, say, the alpha synuclein disorders like Parkinson's disease. Just a little bit about the cataplexy that we see in narcolepsy type 1. Cataplexy, if you are convinced that what is being described as cataplexy, is very specific for narcolepsy type 1. There's just not a lot of other things that manifest as cataplexy. But there's lots of reasons why people have funny spells of things. So it's worth drilling down about what the experience of cataplexy is typically like. So usually it has a duration of seconds, can go up to about 2 minutes. It can go longer than that. It is just uncommon for it to do so. The typical presentation is less than 2 minutes. Most commonly, the neck or the face or the limbs are involved. It is usually bilateral. Consciousness is retained. People aren't falling asleep. People aren't passing out. They have a sudden loss of muscle tone that is induced by emotion, but it is a problem of tone, not a problem of consciousness. If you happen to see somebody having cataplexy in front of you, it's helpful to check their reflexes and see if you can find them. If they are indeed having cataplexy and it is generalized, you should not be able to get reflexes. If it is a partial attack, meaning it doesn't affect the whole body, you shouldn't be able to get a reflex in the muscles that are affected. Early studies suggested that strong emotions were common for triggering cataplexy, the most common being laughter, hearing or telling a joke, and the second most common being anger. I would say more recent studies have suggested that really it's more common to have cataplexy with strong positive emotions than with strong negative emotions. Although patients are atonic, it is possible to see some positive phenomenon that can be misinterpreted. So if you think about what you see during REM sleep, although people have REM atonia, you can see a tiny little bit of phasic muscle twitching, especially in the face. And so similarly, when someone has cataplexy, and their emotion has triggered their REM atonia system to turn on, you can see that similar sort of phasic twitching. So you're not going to see large jerks, you're not going to see large movements across joint spaces, but if you see a little bit of phasic muscle twitching in the face, that can be a good clue that this really is cataplexy that you're seeing. In kids, cataplexy can manifest very differently than it does in adults, and that may be one of the reasons why this diagnosis is particularly challenging in kids. They can actually manifest almost dyskinetic movements during their cataplexy. So narcolepsy type 1 is a problem of sleepiness for sure. It's one of the central disorders of hypersomnolence, but I think it's helpful to think of it not so much as a disorder of sleepiness, but as a problem of state control. And by that I mean, it's normal for us to be in REM or not in REM, or in non-REM or not in non-REM, or awake or not at any given time. We don't slip between those three states. People with narcolepsy slip between those three states, and that is the problem. So they are awake during the day until they fall asleep. That's where the sleepiness comes from. But they're asleep at night until they fall awake. That's where the fragmented nocturnal sleep comes from. Cataplexy is REM atonia, intruding on wakefulness because of emotion. Sleep paralysis is the persistence of REM atonia after wakefulness. The hallucinations maybe are a manifestation of REM imagery. And then REM behavior disorder is sort of the inverse of cataplexy. It's the loss of normal atonia during REM, even though the brain is otherwise in REM sleep. So state control is really the problem in narcolepsy. What about on the other end, which is idiopathic hypersomnia? Although it is also a disorder of sleepiness, it is a very different disorder of sleepiness than narcolepsy type 1. So to meet the ICSD-3 criteria for idiopathic hypersomnia, you have to have daytime sleepiness lasting at least 3 months. You can't have cataplexy. You cannot have more than one sleep onset REM period between the nighttime study and the MSLT. And you have to rule out all other causes of sleepiness. Very important here, as always, to rule out insufficient sleep durations, because those can look just like idiopathic hypersomnia. Circadian rhythm problems can also mimic idiopathic hypersomnia. And then you have to have one objective measure for the diagnosis of idiopathic hypersomnia. a mean sleep latency of less than or equal to 8 minutes on the MSLT, 24-hour PSG demonstrating at least 11 hours of sleep. Those are hard to get in the US, if not impossible, but those are used in Europe sometimes. Or actigraphy for at least 7 days, showing an average of 11 hours of sleep. It is worth noting, and is noted in the ICSD-3 that the actigraphy criteria have not been validated for the diagnosis of idiopathic hypersomnia. It was more that they wanted to somehow capture this diagnosis. The MSLT does not perform very well for this. Lots of people you think have idiopathic hypersomnia will have a normal mean sleep latency on their MSLT, and so these duration criteria were added. Because we can't get PSG in the US for 24 hours, actigraphy was added, but certainly still awaits further validation. If you look at old literature, you will see idiopathic hypersomnia with long sleep time and without long sleep time. That was taken away in the ICSD-3 because we're not really sure where that line should be or if those two diseases are different from each other. People with idiopathic hypersomnia often have very, very great difficulty waking up. Sometimes this is referred to as sleep drunkenness because they are so impaired during the period of trying to wake up. People with idiopathic hypersomnia will often take naps that are more than an hour in duration, and they wake up feeling worse than when they went to sleep. And on a sleep study, you would expect to see a normal or high sleep efficiency, so 90% or above. The ICSD-3 does point out that even if you use 24-hour sleep time on actigraphy and MSLT, you still might miss people that you think have idiopathic hypersomnia. And so you may need to use your clinical judgment and say, I still think this fits the pattern of idiopathic hypersomnia, even though our tests are not showing the classic findings. In that situation, they say, of course, rule out other things and think about maybe repeating the MSLT. Unlike narcolepsy type 1, which is a problem of state control, idiopathic hypersomnia is really a problem of hypersomnia. These are people who sleep well or better than normal, sufficient duration or long, and are sleepy despite that. We really don't know the prevalence. It is classically taught to be rare. It's hard to find data in support of that statement other than people's individual clinic populations, which certainly are subject to referral bias. In the DSM, for psychiatric diseases, hypersomnia disorder is the equivalent to idiopathic hypersomnia. A population phone survey showed that that disorder is actually probably about 0.5% of the population. And so potentially that cluster of symptoms may be much more common than narcolepsy type 1. It has a similar age of onset, often late adolescence or early adulthood, as narcolepsy type 1. There is probably a female predominance in idiopathic hypersomnia, and people with idiopathic hypersomnia often have a family member who has one of the disorders of excessive sleepiness or similar symptoms. So you'll notice I jumped right from narcolepsy type 1 all the way to idiopathic hypersomnia without talking about narcolepsy type 2. And the reason that I did that is narcolepsy type 2 really in a lot of ways fits in the middle between narcolepsy type 1 and idiopathic hypersomnia. It's not that we think the pathophysiology of the three is some sort of spectrum, because we understand what causes narcolepsy type 1, and it's got to be something else for narcolepsy type 2 and idiopathic hypersomnia. It's just that if you look at the symptoms, you tend to see patients with narcolepsy type 2 sort of falling in between those two extremes. Probably, at least in part, that's because some people that we're calling narcolepsy type 2 actually have hypocretin deficiency that we're not testing for because they don't have cataplexy. And so we're sort of mislabeling them type 2 when they're really type 1. And probably there are some people who get labeled narcolepsy type 2 who really have idiopathic hypersomnia. We don't understand those two diseases well enough to separate them out consistently. The only thing that separates those two is one REM onset on the MSLT. And we know that if you repeat the MSLT, that can change. And so it's not necessarily that the diseases are on a spectrum in terms of their biology, but the way the symptoms present, they can look like a spectrum because maybe those narcolepsy type 2 patients have some misclassification in there. So one of the papers that I think was really instrumental in demonstrating this was a cluster analysis that was done using the old ICSD-2 criteria, where they basically looked at the MSLT results, but also clinical features like cataplexy and characteristics of naps. They threw it all into a computer and said, sort these people into clusters. And what happened is there's a very clear cluster that captures almost all of the narcolepsy type 1 patients. There's a very clear cluster that captures almost all of the idiopathic hypersomnia patients who habitually sleep at least 10 hours. And then there's this cluster here that captures the idiopathic hypersomnia patients who sleep less than 10 hours and the narcolepsy without cataplexy patients. And so again, there's some overlap in symptoms there, especially between the narcolepsy without cataplexy and idiopathic hypersomnia without sleep time, that can make that distinction difficult, if not perhaps impossible. So here's what I mean when I say the symptoms present as something that looks like a spectrum. So the narcolepsy tetrad, you only see in narcolepsy type 1 because of the cataplexy. You don't see it in all patients. About 40–45% have the whole tetrad. But sleep paralysis is highest in narcolepsy type 1, lowest in idiopathic hypersomnia, but it sure happens in idiopathic hypersomnia patients, and intermediate in narcolepsy type 2 patients. Similarly with hallucinations related to sleep, highest in type 1, lowest in IH, intermediate in narcolepsy type 2. Fragmented nocturnal sleep is very common in narcolepsy type 1 because it is a problem of state control. It is very atypical in idiopathic hypersomnia because that is a disorder of hypersomnia. Narcolepsy type 2 is not as well studied. There is, in a consensus paper, this statement that fragmented nocturnal sleep may be common in narcolepsy type 2. I think if you dig into the data, you will see that fragmented nocturnal sleep is more common in people with narcolepsy type 1 than with narcolepsy type 2 or idiopathic hypersomnia. So this is a study where the narcolepsy patients were not lumped, but were split by the absence of cataplexy or the presence of cataplexy. And you can see on a variety of sleep measures, people with narcolepsy type 1 have fragmented sleep that is less of an issue for narcolepsy type 2 and idiopathic hypersomnia. REM behavior disorder, at least mild cases, is not uncommon. Maybe half of people with narcolepsy type 1 really has not been well quantified in type 2 narcolepsy or idiopathic hypersomnia. You would certainly not expect it in idiopathic hypersomnia, maybe some in narcolepsy type 2. Long nocturnal sleep times are common in idiopathic hypersomnia. They are less common in people with narcolepsy. There was a study that looked at narcolepsy patients as a whole and showed that 18% of them had long sleep times. In fact, most of the patients with long sleep times had narcolepsy type 2, not narcolepsy type 1. The nap effect is important. People with narcolepsy type 1 can take a 15-minute nap and wake up and feel much better. People with idiopathic hypersomnia can try to take a 15-minute nap, wake up 4 hours later, and feel much, much worse. Sleep drunkenness, the difficulty with waking up, present in about half of people with idiopathic hypersomnia, pretty uncommon, but occasionally present in narcolepsy type 1. There is a number here for narcolepsy type 2 of 47%, but that's based on a very, very small sample in the literature. It really hasn't been studied well in narcolepsy type 2. All right, so that's sort of the clinical landscape. What about pathophysiology? This section is shorter because there's a lot we don't know. We don't know, for example, what causes Klein-Levin syndrome, so I won't talk about that. We don't know what causes narcolepsy type 2, so I won't talk about that. What I will talk about is what causes narcolepsy type 1. So we have known for a long time, about 20 years now, that people with narcolepsy type 1 have lost their hypocretin-producing neurons in the hypothalamus. So you're actually looking at autopsy slides. You should have lots of black dots, which are hypocretin neurons or orexin neurons. Again, two words for the same thing. People with narcolepsy type 1, those cells are either dead or quiescent. There's also been this idea for quite some time that narcolepsy type 1 might be autoimmune, and in part that's because of the strong association with the HLA DQB10602. So early studies suggested sort of a variety of different HLAs associated with narcolepsy. The one that is most strongly associated is this DQB10602. The slide says it's positive at 85% plus of patients with narcolepsy and cataplexy. To some extent, that's due to the difficulty in diagnosing cataplexy. If you look for people with narcolepsy and hypocretin deficiency, it's about 97, 98% of them are also positive for this DQB10602. So it is almost mandatory to have this HLA in order to have narcolepsy type 1. It's not really useful clinically as a diagnostic test because it's also positive in about a quarter of controls. But the fact that it's an immune modulator or part of the immune system suggests maybe this is an immune problem. And where the story got really interesting was when a genome-wide association study of narcolepsy showed that narcolepsy type 1 is associated with a single nucleotide polymorphism in the T cell receptor gene. And so now you have both the antigen presenting cell implicated through the HLA and the CD4 cell implicated based on the T cell receptor. And so it suggests that that is the way that the system could be recognizing self. And then this happened, which was the H1N1 pandemic, and very quickly there were H1N1 vaccines, and unfortunately in August of 2010, after the 2009 flu season, the first reports came up suggesting that people were developing narcolepsy shortly after receiving a particular kind of narcolepsy vaccine called Pandemrix, which was not, for what it's worth, what was used in the United States. A number of countries used Pandemrix and found an increased risk for narcolepsy after H1N1 vaccination. These numbers are hard to estimate because once the first report came out, then there is potentially some ascertainment bias and some recall bias and other things. But at least in kids who receive Pandemrix in Europe, this looks like a pretty strong signal. I'm very pro-vaccine. Everyone, please get all your vaccines. This, if anything, is an example of the vaccine surveillance system working well because they realized this vaccine was a problem pretty quickly, and it no longer is used to vaccinate people against H1N1. It's also worth noting that if you just get H1N1, not the vaccine, but the infection itself, that's also associated with narcolepsy onset. So these are data from China, where H1N1 vaccine was not widespread, and right after the H1N1 pandemic, they also saw a spike in narcolepsy diagnoses. So it's not the vaccine per se, it's something about the H1N1. And sort of one more step towards saying it's autoimmune, what's happened very recently in the last year and a half or so is people have started to demonstrate that people with narcolepsy have circulating CD4 cells and circulating CD8 cells that are reactive to self-hypocretin. And so that's really what you need to say that there is an attack on the self. It helps to be able to demonstrate these autoreactive cells. There are still some features of autoimmune disease that narcolepsy does not quite fit, or at least has not been demonstrated yet. So I think some people say it's not for sure autoimmune, but there's strong circumstantial evidence that an autoimmune response in people with the appropriate genetic HLA-DQ102, the second hit is probably an immune thing. Doesn't have to be H1N1. Narcolepsy happens in years isn't H1N1, but some sort of infection triggering likely this immune process. There's nothing to say about idiopathic hypersomnia really either because we don't know what causes it. I will say there are some theories that are out there. There is some data suggesting that people with idiopathic hypersomnia have something in their spinal fluid that turns on GABA-A receptors, and GABA-A receptors, things that turn on GABA-A receptors tend to be sedating, so that might be the cause. There's some data to suggest there's autonomic dysfunction, certainly in terms of symptoms. People with idiopathic hypersomnia often have orthostasis and vasomotor autonomic symptoms. One small study suggesting changes in heart rate variability during sleep, so maybe an autonomic dysfunction. Although you have to rule out circadian rhythm disorders per se to diagnose idiopathic hypersomnia, people can't have like delayed sleep phase as the cause of their sleepiness. There may still be some circadian dysregulation in idiopathic hypersomnia. There's some work now looking at BMAL1 and PER1 and PER2 and sort of their gene expression profiles. And also the circadian period that is measured by BMAL1 that there may be some dysfunction in patients with idiopathic hypersomnia, but this is still very much a work in progress. We don't know what causes idiopathic hypersomnia. So what about treatment? And this is to some extent treatment of narcolepsy because that's where the best evidence base is. But what we do for all of the others where there isn't as much of an evidence base is we sort of take the strategies that work for narcolepsy and hope that they will work for the other conditions. At least until we have sort of better data. So non-pharmacologic strategies, I would say for most patients are not going to be sufficient, but they may still be helpful. For narcolepsy type 1 patients, it has been shown in a controlled study that if people are already on stimulant medication, if you add a regularly scheduled nocturnal sleep times and short scheduled naps during the day, you will improve sleepiness compared to stimulant medications alone. Not if you just schedule nighttime sleep, not if you just schedule naps, but if you do both, short naps can help in narcolepsy patients. So often it is our role to help people get reasonable accommodations for school or work. If they have type 1 narcolepsy, being able to go somewhere and take a nap for 15 minutes can make a huge difference in their functional status during the day. Counseling and support, I think, is important for all of these diagnoses. They're hard diagnoses to get. They happen when people are young and are still figuring out their lives, and can have implications there. There's also safety counseling about falling asleep driving and having cataplexy while you're on a ladder, as well as sort of more typical medical counseling like side effects. I do think patient groups can be very helpful. The Narcolepsy Network and Wake Up Narcolepsy are two of the narcolepsy groups that are national, that offer a variety of resources. Non-pharmacologic strategies for idiopathic hypersomnia are going to be different than they are for narcolepsy type 1, predominantly around the fact that naps are not helpful. Naps in IH patients are long and they're unrefreshing. And so most people with idiopathic hypersomnia, it's not going to help them have an accommodation that nap. Some of them, because they tend to be phase delayed, having a later start time, giving them time to get over the drunkenness can be helpful. And similarly, counseling and support. The AASM practice guideline for these disorders is from 2007. There will be a new one very soon, but there's not a new one now. So here's the current evidence. Standard is the highest level guideline. Intermediate and option is the lowest. And you will see for narcolepsy, modafinil and sodium oxybate are standard. Amphetamines are guideline because there's just fewer controlled trials because these medicines are old. And so there's not as much money to invest in doing randomized controlled trials. For idiopathic hypersomnia, modafinil is an option, as are amphetamines. And then for Klein-Levin, modafinil and amphetamines sometimes wake people up during Klein-Levin, but then they're like angry and altered. So that might not be great. Lithium was an option level in this practice parameter. Subsequently, there was a fairly large series of patients with Klein-Levin suggesting that lithium does probably reduce frequency, severity, and duration of attacks. And so at least in my practice, lithium is the thing that I think about first in terms of trying to prevent Klein-Levin spells. In terms of the treatment of cataplexy for narcolepsy type 1, the AASM treatment guideline gives the highest recommendation to sodium oxybate, a lower recommendation to your antidepressants, again, because of sort of lack of data. This is the landscape of treatments that are FDA approved for either kind of narcolepsy. The FDA doesn't care whether you have narcolepsy or type 1 or type 2. The two in black were approved for the treatment of narcolepsy in 2019. So we're still trying to figure out where they fit in the overall treatment algorithm, but worth knowing that we have those two new medications. On this list, sodium oxybate is the only one that's FDA approved to help with both sleepiness and cataplexy. Pitolisant has been shown in randomized controlled trials to help with both sleepiness and cataplexy, but is only FDA approved. Modafinil and armodafinil. Modafinil is a racemic mix of two mirror image compounds. Armodafinil is the right-handed one of those two. So they act very similarly, but they are not identical. They have different dosing. So the maximum dose of modafinil is 400. The maximum dose of armodafinil is 250. And so if you're switching between them, you need to take that dosing into account. They also have a different functional duration of action. Of the two enantiomers in modafinil, the right side, it has a longer functional duration of action. And so most people who take modafinil take a dose in the morning and then a dose around lunchtime. Most people who take armodafinil can take one dose in the morning and it will last them all day. And so an advantage to armodafinil just in terms of ease of use. Side effects to think about are irritability, nervousness, anxiety, palpitations, headache, nausea, rhinitis. Modafinil and armodafinil are associated with very severe drug rashes like Stevens-Johnson, especially in kids. Rarely things like mania and psychosis. They're Schedule 4 by the FDA, so there is some risk of abuse and dependence and can cause angioedema. Modafinil and armodafinil interfere with hormonal birth control to make hormonal birth control less effective as birth control. So any woman who is put on modafinil or armodafinil who is vaguely within childbearing age should be told about this all the time. So they should use an additional or different kind of birth control for the purposes of pregnancy prevention while on modafinil, armodafinil, and for 28 days after their last dose of those medications. Outside the US, the EMA and Health Canada have now said that modafinil should not be used during pregnancy based on some birth defect data from a registry. The FDA has not changed their pregnancy labeling, but know that these drugs are probably not safe in pregnancy, which parenthetically is true of all of our medications that we use for narcolepsy. Amphetamines and methylphenidate, often patients do well with a combination of an immediate release and an extended release to sort of get through the day, but then hit them at their worst parts. Similar side effects in terms of anxiety, palpitations. These are more likely to raise heart rate and blood pressure, and they have black box warnings for things like drug dependence and abuse potential. They are Schedule 2, which means they are more liable to cause drug dependence. Sodium oxybate is a sodium salt of GHB, and so it's distributed through a restricted distribution program to try to keep supply tight, so you can't go to CVS and pick it up, you have to have it mailed to you. It's dosed at bedtime and then 2.5 to 4 hours later. It's a short half-life. It's the only medication of the narcolepsy medications you take at bedtime rather than during the day. It helps with sleep consolidation, it helps with sleepiness, it helps with cataplexy, it can help with hallucinations and paralysis as well. It does cause bedwetting, nausea, and sleepwalking, and in the clinical trials and definitely in clinical practice, there are clinically significant mood changes and thought changes in a fraction of the drug. It's small, but it definitely happens. And for people with psychiatric history, you have to certainly be very cautious. The sodium oxybate in his name is no accident. It has almost 100%, it's like 80 something of your daily sodium intake just in the medication. So people have to be advised to reduce their salt in other ways. It also has black box warnings because it's a CNS depressant. People definitely cannot combine this with any sedating medications. People have to give up drinking alcohol because of the risk of CNS depression. And then respiratory depression, because it's GHB, sodium salt, there is a abuse potential and a misuse potential as well. Solriamfetol is a dopamine and norepinephrine reuptake inhibitor that was just approved for narcolepsy or sleep apnea. It's Schedule 4. Here, sort of the pivotal clinical trial data, where basically they found that the Epworth improved between 2 and 4.5 points, and the MWT, ability to stay awake, improved between 2.5 and 10 minutes. The FDA approved a starting dose of 75 and a maximum dose of 150. The adverse events are similar to what we see with modafinil and the stimulants. It's working on similar chemistry. It also is known now from the clinical trials to increase heart rate and blood pressure. On average, that increase is small, about 2 points, but in some people will be clinically significant. Tolisant, also approved in 2019. It is the first histaminergic drug. It's an H3 antagonist and inverse agonist, which means that it promotes CNS histamine neurotransmission, and histamine is part of the reticular activating system that wakes us up. So only approved for narcolepsy, not for sleep apnea. It is not a scheduled drug. It's not even Schedule 4, but you have to get it through a specialty pharmacy. So you have to fill out a form and fax it to the pharmacy. Here's the data from the clinical trial showing that it is much better than placebo. The effect you see is broadly similar to what you see with modafinil in that same study. Also, in a separate study, decreased cataplexy by about 75%, which is about 40% placebo. Headache and insomnia were more common with tolisant than modafinil. Otherwise, kind of similar side effects to what we see with the other drugs. Few serious side effects in this small clinical trial. It also interferes with hormonal birth control. So women put on tolisant also have to be told to use a backup or an alternate method to their oral contraceptive pills for pregnancy prevention. Also, not on this slide, pitolisant at the highest dose does cause prolongation of the QT interval. And so avoid using it in other drugs that increase the QT interval or in people who have a history of prolonged QT interval. And with that, I thank you so much for your attention, and I'm happy to take some questions. While you all are typing, someone managed to type while I was talking, so I will start with that question, which is, why is CSF orexin level not the standard to diagnose all patients with narcolepsy type 1? And I think the reason is, historically, there's been no way to test hypocretin levels or orexin levels outside of sort of a research context. You could send it to Stanford, but there was no clinical lab testing for hypocretin. So it's sort of hard to make that part of the diagnosis if it's something people can't get. Now that it's clinically available, it'll be interesting to see how that changes. Not everybody is excited about the idea of having a spinal tap. And not everybody probably needs the spinal tap in cases where it does not seem equivocal. Lumbar punctures have a worse reputation than they deserve, but they are still an invasive procedure that if you can avoid them, maybe you don't always need them. Oh, so another great question, which is if the CSF hypocretin is normal, do you need to get the HLA? And I would say we tend to think of that in reverse. So the HLA is not part of the diagnostic criteria at all. It doesn't show up in the ICSD-3 as part of the criteria. So you never need to get HLA testing. And in fact, in most patients, I would say we don't get HLA testing. HLA testing is not helpful if it comes back positive, because the HLA is so common in controls that a positive test really doesn't help you. Where the HLA is negative, whether HLA is useful is if it's negative. So if you think somebody, maybe their cataplex is kind of weird, there's something about the story that's not right, and their HLA is negative, it's going to really push you with saying, this really isn't narcolepsy type 1. And people in whom you're considering doing CSF testing, look at hypocretin, because virtually everybody with low hypocretin and sleepiness has that HLA. If the HLA is negative, some people would then not do the spinal tap. So do the HLA first if you're considering a spinal tap, and then don't do the spinal tap if the HLA is negative. All right, that looks like all. Oh, somebody commented that the HLA is positive in about 25% of people, and actually so is a mean sleep latency of less than or equal to 8 minutes, which yes, I concur. This is a big problem with our diagnostic testing, is that the never mind the HLA isn't that useful for diagnosis. There's pretty good data that the MSLT can be abnormal in a big fraction of the general population, as well as being normal in some people that you're pretty convinced have a hypersomnia disorder. So the MSLT undoubtedly has both sensitivity and specificity problem. All right, that does look like all the questions. I thank everyone for your attention today.